Hello, everyone, and greetings on this Tuesday. We are so excited to have our third installment of the Power Hour with the Partnership for a Healthy Mississippi, and I'm very excited about today's call. As many of you know, it is February. Yesterday was our Love Day, Valentine's Day. But I noticed a lot of people around the office didn't have on red, and it was because the week before we had celebrated Wear Red Day in honor of Heart Health Awareness Month. And so today we're going to really focus a lot on heart health. A couple of reasons for that, in addition to it being, Go Red Month and raising awareness about heart health. Mississippi, unfortunately, has high incidences of heart disease. And I'm sure you're going to hear from our speakers today that some of it is, yes, some of it, you can blame grandma for the bad genes, but a lot of it, the higher percentage of it is going to be behavioral in nature. We can make some changes early on that may prevent us and from getting heart disease and all the health problems that can come with that. So I am very excited today to welcome two wonderful people to the call. Our first speaker today is Jennifer Hopping. And Jennifer is the Executive Director of the American Heart Association. And she will tell you a little bit about her role there. She's been in that role for 11 years. And then our second speaker, we're very fortunate to have. He is the cardiologist at UMMC, and it's Dr. Bradley Deere. So I'm gonna turn it over to Jennifer. Oh, wait, and I'd be remiss if I didn't tell you. We have some handouts that have been provided by the speakers, and they are available for you to follow along on our Facebook page or on our website. And so the Facebook page is the Partnership for a Healthy Mississippi. Our website is healthy, HEALTHY -MISS.org, healthy-miss.org. So without further ado, I will turn it over to Jennifer. Jennifer, if you will start fix yourself and unmute yourself, you're up.
Okay, sorry, can y'all hear me now?
Yes, we can.
Okay, sorry, I forgot how to unmute myself. I was a couple minutes late hopping off another call. As Sandra said, I'm Jennifer Hopping, and I'm Executive Director at the American Heart Association. And of course, this is Heart Month, as Sandra said, and so I know you hopefully have all seen just a lot of awareness this month. I think it is our, as I said to some of it, this is like our Super Bowl, is where Red Day kicks off our month of awareness. And so we're just thankful that we were asked to be a part of your call today. And as Sandra said, I have recruited Dr. Bradley Deere from UMMC. I talked to one of my board members that's also a cardiologist there, and he said that Dr. Deere is really focused on prevention. And I think, that's so important for the American Heart Association, is that we really, unfortunately, heart disease is the #1 killer of Americans and of Mississippians. And so as an organization, we know education is really the key to that. But also, as an organization, we're really trying to create access to things like healthy foods, access to health care, access to education, because if you don't have those things, the prevention is even harder. And as we know in our state, unfortunately, we have a lot of areas that really struggle with those core needs to live a healthy life. So I think what we're going to do, Sandra, if it's okay, I'm going to let Dr. Deere probably speak first, and then I'll talk a little bit about our work throughout the state of Mississippi, if that works for y'all.
Sounds great.
Okay, Dr. Deere, are you on? It's *69. I had to remind myself how to unmute.
All right. Okay, I think I did it.
Gotcha.
I'm unmuted.
Yes.
All right, perfect. No, of course, yeah. I think it's. Thank you so much, Sandra. Thank you so much for this perfect segue. And yeah, I think it will be great if I go ahead and just dive in, kind of go over how I approach cardiovascular health and prevention. And thanks for the kind introduction. But like everyone, like we said, I'm Bradley Deere. I've actually been practicing here as a general and preventive cardiologist for about a year. I went to medical school at UMMC in Jackson, and then went down south a little bit to New Orleans, and I was fortunate to do my medicine and cardiology training at Tulane University in New Orleans. And during that time, I had a wonderful mentor, Keith Ferdinand, who was really kind of a pillar in preventive cardiology. And so I was able to take a lot from him, became very passionate about this, and it's just continued to grow, and it's definitely keeping me busy. And I think a good way to kind of start off with this is, one, reemphasize that yes, it's as of the most recent statistics, cardiovascular disease is it's the leading cause of death in the world and in the United States. Cardiovascular disease claims more lives than all forms of cancer and lung disease combined. And when you break it down to what is within cardiovascular disease, what's kind of attributing to these deaths, we have coronary artery disease, we have stroke, high blood pressure, heart failure, other diseases of the artery, so like peripheral artery disease, and then there's still other forms of cardiovascular disease. So this is obviously a very broad-reaching disease process, and we have to take a lot of steps and how we can A, prevent it, and B, treat it and manage it once it manifests. So I thought it would be helpful if I just kind of walk through and talk about how I kind of approach it whenever we have, a patient coming into clinic. And kind of taking a step back, though, I should mention a few things. When we talk about prevention, there's different aspects of prevention. So primordial prevention is where we're trying to prevent the onset of risk factors that lead to heart disease. And that's typically geared at folks at a younger age. And looking at some, Jackson Heart Study, Bogalusa Heart Study, we know that there are risk factors, hypertension, hyperlipidemia can develop at younger ages than what people previously thought. So this type of population, we're focusing more on primordial prevention. Primary prevention is where we're trying to prevent the onset of cardiovascular disease, such as heart attacks and stroke. And then a lot of my patients in clinic are there for secondary or tertiary prevention. So folks who've already had a prior stroke or have had coronary stents placed, we want to reduce the risk, any residual risk that they may have, to try to prevent any recurrent events, because we know that folks who've already had one type of cardiovascular event are much higher risk of having more in the future. So whenever somebody comes into clinic and we want to see what is their risk, people come in very often as, hey, doc, what's my risk of having a heart attack? I have XYZ, I'm concerned about this. And then sometimes people have symptoms and you want to know, are these symptoms attributed to some underlying cardiovascular disease? I like to break it down, and as Sandra, you mentioned it earlier, there's some things we can control and some things we can't. We can't pick our age, or if we can't pick our parents, then we can't really fix our age. We get older each year, and age is one of the big risk factors for cardiovascular disease, and then our family history. If you have a sibling or a parent who had a heart attack at a young age, so less than 50 or less than 60, depending on just your mom, dad, or male, female, your risk is almost double just by having that family history. The other type of risk factors where we look at modifiable. So I always go through this with each patient. These are the ones that we can have some control over. Cigarette smoking is still one of the biggest issues that increases the risk. Diabetes, high cholesterol, obesity, physical inactivity, and unhealthy diet. There's still a whole nother category of where I kind of like the more recent guidelines with AHA and ACC relatively fixed risk factors. So I would actually put family history in that, the increased age, like I mentioned, but also things like socioeconomic, social determinants of health. Chronic kidney disease is also something that a lot of folks don't think about. Obstructive sleep apnea, psychosocial stress, among some other things that fall into this relatively fixed risk category. And so we kind of go through these things, and we want to try to make sure we're not missing anything. And we call it the Life Simple 7 is a way to. I laugh because I always say it's simple, but it's really not that simple. Otherwise, we wouldn't have as many issues as we do. But looking at those risk factors, we come up with Life Simple 7, and the goal is to maintain cardiovascular health by, number 1, being active, 2, keeping a healthy weight, 3, learning about cholesterol, 4, stop smoking or do not smoke, 5, eat a heart-healthy diet, 6, keep blood pressure healthy, and then 7, learn about blood sugar and diabetes. So each of these things can take up quite a bit of time, and there's a lot of nuance to each of these categories. But the goal is to try to tailor, each regimen, tailor whatever you need to enter, whatever you want to do to prevent cardiovascular disease with each person, depending on if somebody has issues with cholesterol, or if somebody has a family history of heart disease, or if somebody's having trouble with high blood pressure. So let me go ahead and take a step back and step back into, let's say we're in the clinic and you're the person who's asking, what's my overall risk? We start by going through those risk factors and seeing if you've been assessed for it, and kind of where you fall out in terms of how you're doing on each of those different measures within Life Simple 7. After that, I typically will do that's more kind of a qualitative, we're talking things through, but then it's always helpful to do a quantitative risk estimation. So we have a risk calculator. It's available online. It's ACHA pooled cohort equation. And so it's something that your primary care cardiologist, anybody can use to help give a somewhat objective overall 10-year risk of having an atherosclerotic cardiovascular disease event. And so I use that. Then a lot of times there may be some of these other risk-enhancing factors like family history that we mentioned earlier. And you pull all these different things together, and that can give us where you stand about your overall risk over the next 10 years, and eventually lifetime risk of cardiovascular disease. Meanwhile, though, the whole time going through this, and what we want to implement with every patient is healthy lifestyle measures, and that is also one of those things that's easier said than done. And we can go into, maybe at a later date, all the different methods that we can do and implement in terms of diet, exercise, weight management. So I do think that's a overall basic approach. And one thing I do always emphasize to each patient is, let's say even if you have borderline blood pressure, you have mildly elevated cholesterol level, one approach that seems to help folks kind of understand is that it's really how long we're exposed to these risk factors. So if you may have heard of before that cigarette smoking, folks have tobacco exposure over a certain period of time or pack years, you could think of the same for cholesterol. So the number of years that you're exposed to high cholesterol levels, or the number of years that you're exposed to higher than average blood pressure levels, your risk continues to increase over time. And so our goal is to, one, identify folks who may have higher than average blood pressure, higher than average blood sugar, higher than average blood cholesterol levels, and reduce that risk over time to help reduce the risk over time by reducing the amount of exposure you have to those risk factors. So there's definitely a lot of aspects within this, and I'm hoping that this kind of helps give a general idea of what we're looking at when we say preventive cardiology and what we can do to approach a patient who may be at risk. And there's also lots of other diagnostic and imaging and testing modalities that we can use to help refine somebody's risk a little bit further. I think as long as you're working within the framework of Life Simple 7, that's always a great starting point. And within each of those 7 concepts of physical activity, maintaining weight, then your cholesterol diet, cholesterol, tobacco, blood sugar, and high blood pressure, we can always identify risks with, in an individual from all those. Let me. I'm going to see.
Dr. Deere.
Oh, sorry, go ahead. Mm-hmm.
Would you speak a little bit about the difference in gender as far as how heart attacks present themselves? I know there are a lot of studies really focused on men and, the typical down the left arm and certain things that we've heard, but women present differently, correct?
Right.
Can.
No, I'm so glad you asked that, because I was debating whether to go down, because for the first time ever, I think it was around Thanksgiving, we chest pain guidelines came out to try to help clarify and provide some guidance on this very topic, because it's so. For instance, in a lot of the risk factor models, male gender is considered a risk factor, but a lot of that may have just been because it was under-recognized in women in the past. So there's it's almost kind of like a little asterisk on the, the overall prevalence in men may seem greater just simply because it's been recognized more frequently relative to women. But exactly right, for women, the typical elephant on the chest, crushing pain that's unrelenting, and the clutch fist over the chest, bending over, that may not always be the case in women. So it's a lot of times it could just be and that's why I always refer to it as chest discomfort. It may just be an uneasy chest discomfort, a shortness of breath that may have some radiation either to the left arm or to the neck that's going on with this uncomfortable feeling. It typically still will last for about 5-10 minutes and tends to get better with rest. And so there are some slight variations, and just turns out that women will frequently come in with things like shortness of breath or just more of an uneasy fatigue, kind of non-specific. It's not really coming and saying, "Oh, I'm having crushing chest pain right now." So that's one of the slight differences. It definitely is one of those things where even with the new guidelines, they say that there's not exactly you just have to be more aware of it if somebody's coming in without the most typical symptoms, which is substernal chest pain that's alleviated with rest or nitroglycerin and exacerbated by physical activity or stress. So yeah, it is definitely one of those things that it's a little more nuanced. But if you're experiencing anything that comes on suddenly, lasting for more than 5 to 10 minutes and not improving, and the associated symptoms can vary from person to person, but women will tend to have something that's more of a radiation to the left arm and neck. A lot of times shortness of breath comes about with it at the same time. Does that clear up a little bit?
Yes, thank you. And I have one other directional question before you wrap up or whatever. But on stroke, I know that we spent a lot of time talking about heart attacks and all, but I was just reading an interesting article in the New York Times about one of the columnists, Frank Bruni, having had a stroke in one of his eyes. And so, again, I think that stroke is one of those things that there's a lot of assumption that it's going to, be one way. And I know my own mom had some of those mini strokes, but could you say a word about that? Because I know that stroke prevention is all tied up with all of the 7 steps that you were referring to. But I think it's very helpful for us to have some bigger picture about how stroke could present.
Correct, absolutely. And because taking a step back for preventing stroke, preventing heart attacks, it's a lot of the same steps, the exact same interventions. They share similar pathways and they share similar underlying mechanisms and risk factors. The thing to remember with stroke there's still a lot of different categories within stroke. So a lot of it can be due to atherosclerotic disease and hypertension, high blood pressure driving it. And then kind of in your example, a lot of that can be due to atrial fibrillation. And at the onset, I mentioned briefly that cardiovascular health is maintaining, not just preventing and treating coronary artery disease, hypertension, heart failure, but also atrial fibrillation. So atrial fibrillation is essentially just this irregular heart rhythm that comes about as folks get older, and especially if people have risk factors like hypertension and diabetes. And atrial fibrillation, it's something that about 50% of people tend to feel palpitations and irregular heartbeat, but some people don't feel it as much as they really won't feel anything. And the first presentation is stroke, unfortunately. And so the article that you're reading, that most likely was due to atrial fibrillation. But I don't know if everybody here is from the South, and if you have a gumbo, if you're not stirring the road that well, it can clump up on you. That's kind of what happens within your atria if you're in the irregular heart rhythm. That normal blood flow that keeps it nice and loose becomes irregular. Then it starts to clump up, and those little clumps can cause stroke. So that's something where you still want to, identify it. If we find that somebody has atrial fibrillation, we'll treat it and give a blood thinner to help reduce the risk of stroke. But then to prevent the onset of atrial fibrillation, we're going to make sure we're doing all the exact same things that we talked about earlier.
Thank you so much, Dr. Deere. One other thing that might be helpful to people is if you are with someone that you suspect is having a stroke. I know that you call 911, but a lot of our states are in rural areas, and so you might be the person driving someone. What do we look for? What steps can we take as the person right there to help somebody that you think is having a stroke?
Right. So and of course I would want to defer to one of the stroke experts, but the fast mnemonic is one of the first things to think of. So a lot of you will probably see signs or just posts regarding the stroke. But so fast is face, arms, speech, time. So really, it's recognizing if there's a facial droops or speech. Arms is so face and then arms can that person move both their arms or legs. S is speech, repeat a single phrase. So just say, you can come up with any phrase you want. If it's slurred, usually if you're with somebody, you can tell if their speech is off. And then time, you're exactly, you just call as quickly as you can. And that's the main thing to do at that point. If you've done those things, recognized it and called, that's the best thing you can do, and just be there with the person.
And I'll say, Sandra, this is Jennifer. So one thing that Mississippi has done a really great job of is our systems of care across the state. And so the Heart Association has worked with a group called the Mississippi Healthcare Alliance. And so for about the last 15 years, that group, it's a partnership of all the hospitals across the state, along with EMS. And so what I will say is, and I think if you talk, like Dr. Deere just said it, you call always, regardless of where you are in the state of Mississippi. Do you think someone's having a heart attack or B, a stroke? You call 911, and that is your loved one's best chance of having the least issues and outcomes. And the reason that is because across our state, the system of care that's been set up, when you call 911, the EMS is gonna, of course, trigger the ambulance to come to your loved one or to you. And then that ambulance, because of their information and their knowledge, is going to know which hospital to take you to. And so the problem with driving yourself or driving your loved one is you may show up at a hospital and they're not equipped to take care of that loved one. And so another thing is too, if it's, so for heart attack, so if it's a STEMI, which is like they call it the widowmaker, the big one, as Stanford and Sons used to say. So if someone's having a STEMI and you always call 911. Do not try to drive that person to the hospital, because if something happens, first of all, in the car, you can't do anything about it because you're driving them. But the main reason, and I did not know this until I worked for the Heart Association, but the main reason is because when they get to you, that ambulance is going to call the hospital that they're taking you to, and that hospital is going to have their team ready and waiting for you, regardless of what time of day it is. So if you drive your loved one or yourself to the ER, they don't know you're coming. And so you're wasting time. So same thing with stroke. That T for time is just as important for heart and for stroke. So that's a huge benefit that our state has really done a great job with stroke and with STEMI, is that system. So that's why we always say call 911, get them there, and then they'll be ready for you. So if it's a STEMI, they'll take you immediately in and get that cath started if they need to. And same with stroke, they can start the medications that are available. So I would always say the Heart Association, along with Healthcare Alliance, advocates always call 911 when you can.
Thank you, Jennifer.
And I was going to bring this up too, if it's okay to Dr. Deere. I laugh. I tell my friends, like, I'm about to be 40. I'm going to tell my age. I'm about to be 44. And so as a woman, of course, Sandra, as you asked that question, I know my number one health risk is heart disease, regardless of family history. I know that's my number one risk. And so I laugh. I tell my friends, don't ever tell me you're having any symptoms, because I'm going to send you to my cardiologist. And so, Dr. Deere, what would you say, first of all, what age do you recommend someone to actually potentially go see a cardiologist? And what are some of the basic tests that you recommend for someone to really, I guess, kind of evaluate I know you said there's, of course, the online tool, but what are some basic diagnostic tests that people can have done preventatively for heart disease?
Yeah, absolutely. And it's actually, the age group that we're becoming more concerned as being where we want to get concerned is getting lower and lower. One thing that I always, a statistic I always find concerning is that actually when you look from 2010 to 2017, and within the state of Mississippi, the percent change in heart disease mortality among adults 35, starting at age 35, is actually increasing, which is concerning. So basically it was, it's somewhat expected to see higher rates in, the seventh decade and older, but the fact that we're seeing higher rates of cardiovascular disease mortality among 30-year-olds is a concerning trend. So even though a lot of our preventive guidelines, like when do you start statin therapy, when do we actually do these risk assessments, may not be until somebody's in their in mid 40s or 50s. But I very frequently see folks whenever they're in their 20s and when they're in their 30s, because there's a lot of things that go under-recognized. So one instance is familial hypercholesterolemia. Some estimates put it at 1 in 250 Americans have this disease, and their first heart attack, the first presentation, it frequently can be a heart attack. But we'll have 20, 30-year-olds in the hospital who are coming in, athletes, very active people, and then suddenly have a heart attack. So there's always a family history that runs with that. So I guess I can't emphasize family history enough. If you know that there's people, mom, dad, siblings, grandparents who had heart attack or stroke at a young age, less than 60, less than 50, that's one of the first clues that you probably should talk with your primary care and get screened for things like high blood pressure, cholesterol, and have your blood sugar checked. So even starting at the age of 18, that's a reasonable time to at least have one blood pressure check and to have your cholesterol level checked. Talk with your primary care at that point and see, if you do have a concerning family history, plus if your cholesterol levels are high, then you should probably start thinking about other things and being referred to see somebody who specializes in preventive cardiology, or just work with your primary care about things you can do to reduce your risk. Now, let's say somebody's a little bit, so Jennifer, even in your case, let's say, if let's say somebody has high risk based off family history, age, just based off age, family history, maybe some lab levels, and we give, put your numbers into the risk calculator, and it says, you know what, you're in a category that may benefit from risk lowering therapy. So of course, the first step is diet and exercise. But then let's say if your risk isn't quite low enough, that you're comfortable with, then that's when we can talk about doing statin. So a cholesterol risk reduction medicine. I do want to always emphasize that starting a statin, we call it a cholesterol or lipid lowering therapy. And it's true, that's what it does, but it really helps reduce your overall risk, kind of the same as blood pressure medicines. Your blood pressure is still running too high despite good exercise, good diet, we may need to start a blood pressure medicine because both of these therapies help reduce your overall risk. But let's see, starting a medicine and doing it for the rest of your life is a big commitment. And if somebody's at an intermediate range, you're like, I'm not sure if I really want to start something, we frequently use a coronary artery calcium score. We have them at UMMC. I think other hospitals throughout the state, I know all hospitals throughout the state have it. It's just a quick CT scan that takes a snapshot of your coronary arteries. It's non-contrast, very low radiation, almost like doing a chest x-ray. And what this test does, it helps us see if your coronary arteries have had any sort of damage in the past. And it's kind of just a quick snapshot to see where you are. If somebody has a coronary artery calcium score of 0, that's fantastic. And it would actually be very reasonable to not even start a cholesterol medicine, just keep maintaining a healthy lifestyle. You can reassess in about 7 or 10 years. Let's say, though, if you're at a younger age in your 30s or 40s and your coronary artery calcium score is very high, at a higher risk, that's somebody that I would be much more concerned about and be more aggressive with preventive therapies and intervening early on. Sorry, that was a long response.
No, that's great. I felt like you were going to go there. So I have had a calcium score done for those who have not. My cardiologist, I was just like, I just want to make sure I'm all good. And I had one cholesterol test come back a little elevated at my annual checkup. And so I went to my cardiologist and friend, and he did a calcium score test, and it was a 0. So he's like, we're not starting you. You're not recommended to start on any medication at this point, So basically, it's a very easy, non-invasive test for those that have not done it. And you're right, Dr. Deere, most local hospitals, I know in Jackson, I think all of the major hospitals have a it's like a heart assessment testing that you can have done, and it just does some basic tests for anybody that's interested. And so I always recommend people doing that because you don't know what you don't know. And so my encouragement during Heart Month to my friends, and like I said, in our 40s, heading towards our mid 40s, is get your heart checked out. I think. In my role, I hear, unfortunately, stories constantly of younger, as you said, younger and younger people having major heart events. And so I think, one thing that they will all say to everybody that they talk to is, I wish I had known. I wish I had, some checkups, or I go to my regular doctor, but never really had assessed my heart health. And so don't wait until after, be preventative and proactive. I think we have to be advocates for our own health. And Sandra, to your point, I think it's getting better for women, but I do still think we have stories constantly of women survivors who unfortunately their symptoms were very different and it was missed and they had major blockage. And so I think if you feel like, I think what they would all tell you is if you feel like something's not right, keep pushing until you have a physician that's willing to say, hey, let's check this out. So I think that's an important message as well. One of our survivors, she's had 2 events, unfortunately, and she describes, as he said, it's different for women. It's not the crushing pain typically. She said hers was just a weird sensation in her chest. I mean, it was not really uncomfortable. It was weird. And she kept pushing, like her initial test came back normal and she kept pushing and she had major blockage in her main artery And had she not kept pushing, she could have had a major, heart event. So, and she was, P.S., very healthy, exercised, ate healthy in her mid-40s. So I guess I would say that, be sure and just know your numbers, know your risk, and all those things. And I think too, one of the things that the Heart Association's been talking a lot about is stress, right now. And, as a world, we have experienced stress in the last 2 years like we've never experienced before, and mental health, mental well-being. And so the Heart Association has really been looking at the connection between mental health and physical health. And stress can absolutely lead to physical issues with your heart and with other things. So I think it's also important, as we are thinking about this month, our heart health, to take an assessment and look at your overall health. Mental well-being is huge. And I think we are really trying as a country. I think a lot of employers are starting to realize how important this is. What I will say is local hospitals, they have to do community health assessments every 3 years, and this has risen to the top of issues that people are saying they're facing within our state. So I would say, try to erase the stigma of talking about mental health and mental well-being, because it really can truly lead to physical issues with your heart as well. We have studies now that have been done recently really looking at that connection. So truly, stress can kill you. That's what we've always heard. So I think finding that balance, is so important too.
No, that's a lot of, I hope I'm not going over, but it's a lot of great points there. And it's the link between stress and disease has been well established for a while now. I'm glad it's finally, it's becoming more and more recognized that not only is this a real connection, a real association, but it's something that should be emphasized and thought about more and talked about more and treated more. But it's exactly that. With that one, some of the underlying processes that cause stroke and heart disease is it's inflammatory. It's one of the an inflammatory disorder is one of the key things that cause an acute heart attack. And there's just so much data showing how acute stressors in life causes an acute rise in inflammation. And if you have some underlying disease, if you're already at high risk, you're just much more likely to have that sudden onset stroke or sudden onset heart attack. And so yes, it's something that it's well recognized, and it's something that we're trying to aggressively treat with all of our patients.
Hi, this is Sandra again. Jennifer and Dr. Deere. Dr. Deere mentioned early on in his comments that one of the factors can be the social determinants of health. And I know that we're doing a great job with the STEMI, with the trying to heart and stroke prevention when there is an incident. But I know that the Heart Association is doing some work with access to healthy foods. Could y'all speak a little bit more? A lot of the people on the call may have constituency groups that they serve that this would be, really important information is what other resources are out there for those who do live in the rural area, who don't have access to great medical care or to systems of care. So go ahead, whoever wants to.
I could talk about this all day, Sandra, because I've been in this role, as you said, for 11, almost 12 years. And so as an organization, what I'll say is we have completely shifted our focus in the last few years to really looking at equity and driving equitable health across the country, and especially here in Mississippi. So as an organization, we've really kind of drilled down on some key focus areas. Women, of course, is still a huge priority for us as an organization. We're looking at COVID because, of course, as I mentioned earlier, COVID has had huge impact on heart health and community health. Tobacco, vaping, as Dr. Deere said, that's still a huge issue, that we're addressing. Blood pressure, cholesterol. But really in Mississippi, what I will tell y'all is the next core issue is healthy living, which also includes improving nutrition security. And so in Mississippi, we have been working really over the last 4 to 5 years. We hired a community impact director in the Mississippi Delta, and she started there first because we knew that the need there for resources was great. This is not fundraising. This was not raising money. This was truly providing resources and helping address, just as you said, access. So access to education, access to foods, and access to healthcare. So what Helen has done over the last 5 years is work with local communities throughout the Delta to really help connect partners and create resources that they didn't have before. And so now what we're looking at is she's now covering the Metro Jackson area. And so, we think, I live in Jackson and I think, I can run to my Kroger with less than a mile from my house to buy groceries. Well, even in the city of Jackson, we have what we call food deserts, where there is not a local grocery store within walking distance. And so many of our people across the state don't have, access to transportation. And so Helen and I held a community assessment stakeholders meeting last fall, so a little over a year ago. And we talked to community partners across the state. Many were in the Delta. These are folks that are working at other nonprofits. These are people that are at clinics, public health clinics, people that have pantries, across the state, local hospitals, to say, what do you think the greatest need in Mississippi is? Number one was access to healthy foods. So what we are doing now, since that assessment was done in the last year and a half, is we've tried to identify first some funding through local partnerships with companies, with individuals. We're working with some foundations, hopefully, to do some work. And then we're also taking those funds and partnering with local organizations to help create pantries. And to also help create, we've got 2 here in Jackson that are doing local monthly food box pickups. For one group is focused on senior citizens, so 60, 65 and over. And then also the other group is really anybody that needs assistance. And so what I will say is the need is great. We know that, and we are just getting started. And so we're hopeful in the next year, we're working, as I said, on some funding now to hopefully create more pantries across other parts of the state, in places like local health clinics. They're called federally qualified health clinics, and they're all across the state. And there is desire to have pantries within those clinics. There's no funding. And so what we are doing is we are working to find the funding. And then Helen will go and work her magic with those health clinics to create these pantries. We partner with the Mississippi Food Network, which I know many of you are probably familiar with. But it takes time. These partners have to prove that they have the ability to maintain these pantries for a few months before the Food Network can come in and start providing those foods. So that work has really been our focus for the last year and a half, I would say. COVID, of course, it did a lot of bad things. But one thing it did do is it created awareness of the huge gap of food in our state. Mississippi is the hungriest state in the nation. So sink in with that statistic. We are a huge agriculture state, but unfortunately, most of our agriculture it's not foods that we consume. It's feed and things like that. So, that's a huge thing. And then at the policy level, so of course we advocate for policy as well with the legislature. So last year, it didn't happen, but we're trying again this year, really looking at some funding around the SNAP incentives. So for individuals that receive SNAP benefits each month, there's some work being done in other states, which we are trying to replicate here, to allocate additional funds within the SNAP program for individuals when they use their SNAP benefits at places like a farmer's market or a local corner store, and they purchase fruits and vegetables, they get double credit. So basically, they get twice as much credit for healthy foods. So our goal is, you've got to start with the policy too, to really make big change. And so the good news is it's passed the House and the Senate this session just recently. And so the next step, of course, is through the committees. But we're really hopeful that this might come to fruition as well, because we know that that will create some great opportunity for access in other parts of the state with this funding. So our role will be, to advocate for it first, but then also to help some of these local farmers markets and corner stores be set up to then take the EBT cards, because there's some software connected with that. So, what I will say is Dr. Deere talked a lot about heart and stroke and risk factors and all those things, which is so important. And I would say for all of us on this call, probably, we have the education and we knew a lot of these things already. But when you don't know where your next meal is coming from, and when you don't have a doctor that you can go to, and you don't have insurance that can provide access to that physician, that's all that matters. And so that's why the Heart Association is really taking a step back, and said, in order to really change these statistics of heart disease being the number one killer, we've got to address core issues in our communities to help create access. And so that's been the focus of our work, really, for the last year and a half, and will continue to be. And I think, we're telling this story more and more. And what we are looking for is partners. So, Sandra, I think with the work that y'all do, I think the more we talk about this, the more partners we're finding need help. And as an organization, what I will say, the Heart Association, we have a lot of access to a lot of great things that we can provide to these partners that need the help. So I think it's just continuing to identify those partners and who they are, and how we can step in and be a part of that solution. So I hope I could talk about it for days, but I hope that's a good overview kind of what we're trying to do.
That's great. And I think one thing that's very apparent, and we've been doing these calls. We just rebranded them, but we've been doing these calls for well over a year now. But one of the things that's just so important in public health is connecting all the dots.
Yeah.
How diabetes ties into this, how brain health ties into this, how having a livable walking community ties into this. So everything is interrelated. Some of the work that we've been doing is with college campuses setting up the pantries, because a lot of people miss the dots being connected, that we have students that are hungry because their Pell Grant covers their tuition, but it doesn't cover the cost of living and eating. So that's just a quick aside. Sharon, how are we on time? Is it time to open it up for other questions? I feel like I have monopolized the questions.
It is about that time. It is 10:48. So if we have any questions from any of our callers today, please star 6 yourself and you can ask your questions at this time. Well, we have had another awesome call. Thank you so much, Dr. Deere. Thank you so much, Jennifer Hopping, for joining us today on our Partnership Power Hour. Great information. I am going to ask you all, if you all would, I think Dr. Deere talked about this, the 7 things that we really want to look at to make sure that we stay healthy. You said be active, healthy weight. Will you please address those? Just give us a quick overview of those real quick again, if you don't mind.
Okay, yeah, sure, absolutely. So life's simple 7, be active. So maintaining physical activity every day, something's better than nothing. Number 2, healthy weight, whether that's BMI or using waist circumference. And a lot of this information is on AHA's website. So be active, healthy weight, learn about your cholesterol levels, see if you need to get it checked with your primary care. Do not smoke or use tobacco, heart healthy diet, healthy blood pressure, and blood sugar and diabetes.
Thank you so much. And I want to just say something that Jennifer said that I did not realize when you said, don't try to get the person that's having a heart attack or stroke to the hospital, that we need to make sure that we call 911 because the hospital might not be ready. Never thought about that in a million years. So that was a great point that you brought out. And I hope we adhere to that, because a lot of times we're frantic, we don't know what to do, and we're just trying to get them there as fast as we can. But at the same time, if we get them there and they're not prepared and they can't help them, we're really doing them an injustice. So make sure that if we think that they're having a stroke or they're having a heart attack, that we make sure that we call 911 so that they can come in and do what's necessary. Because as they said, time is on their, time is so important in situations like that. And then I'm going to ask also, if you would talk about, you said the face, the arms, the speech, the slurred speech, and as well as the time, if you will address those, because we have a few more minutes before the call ends. Some of the things to look at.
And I will, I've got some documents I will send y'all. I have some Life Simple 7 information that I can send that you can put where people can access it that will recap those. It also will tell you what is a healthy blood pressure, what is a healthy cholesterol. It'll kind of give you those guidelines. And then for FAST, that's the acronym for stroke. So face, arm, speech, and then time. So, get there quickly. I also want to make a plug. We have not mentioned that CPR is a core of the American Heart Association and what we do. I encourage everyone, if you do not know how to do CPR, please learn. And you don't even have to go through any major training to be able to help a loved one should they be in cardiac arrest. We have really promoted this in the last few years of the hands-only CPR, which is just the chest compressions. So if you can look on our website, and it's 3 basic steps. The first step, if someone collapses that you come up on, or a family member, 70+% cardiac arrests happen at home. So odds are it's you or a loved one. But call 911 first, start chest compressions hard and fast in the center of the chest to the beat of the 70s song, Staying Alive. So y'all, that is the basic steps to CPR. And like I said, if you don't know it, please take the steps. There's videos on our website that are very basic, but one of the things we are really promoting too at a legislative level is, I don't know if y'all know this, but right now when you call 911, that person on the other end, depending on where you are, may or may not talk you through those steps. So that's why I say just everybody, the more people that know CPR, the better. The chain of survival is so important. So you would never want to just not know what to do. So I would encourage people that as well. Put that little plug in there.
Thank you again, Jennifer. Thank you again, Dr. Deere, for this awesome session, this information that we need, some of the things that we can do to prevent some of this, but also as they recommended that we start getting our heart checked to make sure that our heart is okay so we won't run into anything later on. At this time.
Hey, and Sharon.
Okay, go ahead, Sam.
One real quick thing. I just wanted to re-emphasize that we will put this information on our Facebook page and on our website, so you will have access to it. Go ahead.
Awesome. Great. If we have any community partners that are on the line today that have a community announcement, please star 6 yourself and share at this time. And I think, Ms. Winters, you're on the call. My phone is connected to all of this, so I didn't want to click on your text message. So please, if you are here and you would like to share that information, please star 6 yourself and share at this time.
I have something as well. This is Joyce.
Okay. Good morning, Joyce.
I want to ask about the 911 call for an ambulance. If something happens, I live in a rural area, and sometimes I think we have just like one ambulance, and it might tell you that it might be an hour before they can get to you because they're in the other part of the county or something. So in that instance, what do you do?
Well, now, it should activate the local fire department as well, right? Do y'all have that?
Yeah, we have
sometimes.
Yeah.
Because they are all, the fire departments are also trained in CPR, and, they usually have an AED, on their fire, truck when they get there. So, and then Dr. Deere, I'll let you kind of respond to that. I know we're not in an ideal area because it is hard sometimes. We're not close to a hospital, and it is, hard to do that. So I'll let you answer that one.
No, and that's a great point. And I don't know if I have the right answer, but I definitely think getting to the nearest emergency department as soon as possible is the best choice always. So if the quickest route is via ambulance, take that. But if it's unfortunate situation or timing or because of that scenario, then and of course I wouldn't delay. I would try to, if you're capable of getting somebody to an emergency department sooner than an ambulance can get there, then I would definitely get to your nearest emergency department. Because I've had several patients who chose to not get checked out earlier because they didn't want to wait, and they didn't think their local emergency department had the resources, or they just wanted to kind of wait and see. But getting to somewhere as soon as possible is definitely the best choice. So if the ambulance can't be there, I would just go ahead and try to get to your nearest emergency department, and then we can facilitate the transfer at that point, because your local ER will definitely have the tools, all the resources necessary to know if you're having an acute stroke or an acute heart attack.
Okay. Thank you so much. And I also have a community announcement as well. I'm with the Harvest County Health Charge and the Mississippi Health Ambassador, and doing a community outreach for COVID-19. If you have not gotten your shot, or if you just need the booster, please get them, because it's very important. And we are also, you can get in contact with me if you need. I'm giving out $25 gift cards for your whichever shot you might get. And thank you.
Thank you. Joyce, would you like to give a contact number?
Yes, my contact number is 662-347-3619.
Okay, Dr. Deere, did you have another comment?
I was just going to say thank you, and thanks to everyone out there who's doing this type of work, and all of y'all, because I always want to look at the best evidence to help improve both my patient and just overall the health impact and the health disparity impact. And the community clinical link is one of the best methods that we have to help improve cardiovascular health equity and to help reduce overall risk for patients. So I can't emphasize the importance of this enough. And so thank y'all for all the work that you're doing.
And this is a community announcement from Choices for Children and Family Medical Clinic. They will be having COVID-19 testing, vaccination, and blood pressure checks on Thursday, February 17th from 10 to 1 o'clock. The location will be 305 Mike F.C. Drive in Yazoo City, Mississippi. Do we have an additional community announcement? Yes,
Miss Sharon, this is Greta Winter. Good morning. Thank you for making that announcement. Good morning.
Good morning. This is Desiree.
I heard you, Miss Winters. And Desiree, go ahead.
Desiree? I'm sorry. I just want to thank you for that announcement. And also, we are working with the community. I'm partnershiping with that clinic as well as DA Carmichael to actually get parents more informed about the vaccine and the booster. And we're trying to, most of all, not just encourage adults, but also encourage children to ask their parents to find out more information. The main thing we're trying to do is get our children vaccinated. There's so many young children, especially infants, becoming ill from COVID and the other viruses. So we're definitely trying to get more information out to them, as well as trying to encourage them, if they haven't been vaccinated, to get vaccinated, and definitely trying to push the subject of them receiving the booster, which will also increase their chances of life in regards to actually catching COVID if that's the situation. So thank you for that community announcement. And that community health fair is being sponsored by our local Yazoo City Police Department. So thank you again for all your assistance and what you do for our community, Ms. Nettles.
You're welcome. And did I hear Desiree? Did you have an announcement?
Yes, ma'am, you did. Good morning, everyone. I am Desiree Norwood, the program manager with the Institute for the Advancement of Minority Health. And I want to invite you all to our Black Men's Health Equity Council meeting. And it's going to be held virtually on Monday, February 28th, 2022. And the starting time is 6:00 p.m. And the featured speaker for that event will be TJ Mayfield. and he is one of the organizers and lobbyists for the American Heart Association, and he's also the Medicaid Extension campaign manager. So if there's anyone that is interested in joining our Black Men's Health Equity Council meeting, please give me a call for more information. And my number is 662-207-3358. Thank you.
Thank you. Any additional community announcements? Again, I will say this has been another awesome call. Thank you, Dr. Deere. Thank you, Jennifer Hopping, for coming on and sharing the wealth of information. Again, community partners, let's make sure that we keep ourselves healthy so we can continue to educate the individuals that we serve on how to have healthy lives and things of that nature. We can't take care of others if we are sick ourselves. So to continue the work in the community that each of us are doing, we need to make sure that we are healthy. So make sure we get our regular checkups and things of that nature and adhere to some of those things that they suggested in the presentation. If we don't have any additional community announcements, I say thank you to our community partners. We could not do it without you. If you have an idea of a topic that you would like to hear on this call, please don't hesitate to reach out to myself, Sharon Nettles. You can reach me at 601-497-9884 or reach out to Sandra, and we will make sure that we can find someone to be able to address the needs of our community. Again, we say thank you, have a great week, and we look forward to you all joining us in 2 weeks. Thank you again.
Thank y'all.
Thank you.
Thank you.